I think we'll call in Dr. Ajit
Just
Kumar.
one question. I want to know this catheter technique. I've never used that. So that means we can use that somewhere else also? I mean, if there is a
Sorry?
bleeding, that catheter technique. I'll deliberately stop you in between to take a picture. What is that? You put a catheter and inflate?
Yeah. So if you have a fresh acetabular fracture, it may not work like that because there is no fibrosis there. The artery will retract into the abdomen. There you will have to pack. But if you have a delayed acetabular fracture, there is a lot of fibrosis happening around the vessel also. So when you have a superior gluteal artery vein, it is still just behind it. Just you can feel.
Can it be done anywhere? Let us say you have a bleeder, you can't see it, and can you just put it and?
You need to have some sort of cavity around it. So this is a very good area where you can put it there. And believe me, it will save you 20-30 minutes.
No, it was very good actually.
Yeah, 20-30 minutes will save you on table. And the frustration of just waiting, sitting and doing nothing. So, Dr. Ajit Kumar.
So, very good morning. Indeed grateful to Dr. Prasad for accommodating me in this meeting. It's a great pleasure to be here. Just my second visit to Cawnpore. So my topic that was allocated was total hip arthroplasty in Coxsavara. Oh, slideshow. Thank you. So basically, we have seen some examples in Dr. Mrinal's talk also earlier, where in DDH also you get this situation. It's not always a high riding hip in a DDH, but post-treatment, particularly when there is AVN, even in DDH you can get a very severe type of Coxsavara. So these are all the causes that are there that are contributory to Coxsavara. Perthes, post-septic sequelae, AVN secondary to DDH treatment, femoral osteotomies, and even some metabolic bone diseases can have these problems. So you have an entire spectrum of pathologies here. You have a short femoral neck. You will have invariably trochanteric overgrowth, and then because of that there will be abductor insufficiency and most certainly limb length discrepancy. All of these in the long run will lead to osteoarthrosis. And nowadays, what the topic that is a bit of a rage, the altered spinopelvic alignment. So there are a lot of issues when we are dealing with severe Coxsavara, and restoring the offset, restoring the limb length and the abductor mechanism is an issue. And sometimes you can have problems with longevity here, definitely. So what are the options that are there? The tapered stem is one option. People have talked about trochanteric osteotomy, and there is something called a trochantoplasty, and apparently that has some issues. I'm not very familiar with that procedure, but that's also discussed. So here, this is not a conventional Coxsavara that you have. It's like a rheumatoid that protrudes into the joint, but you end up with a Coxsavara here, and in correcting that also you have issues. One is you need to get the hip center back to its position. In terms of dislocation, in terms of iatrogenic fractures, there can be a lot of issues here. So a protruded hip is always difficult to dislocate, so you may need to resect the neck first and then ream through carefully to get to the true floor. So all these issues are there. So some of the tips and tricks that are talked about, you can do an adductor tenotomy if needed. If it's very tight, you do it either pre-op or post-op, depending on the situation. You will need to release extensively, most often the iliopsoas, sometimes the gluteus maximus insertion. You may even need to release the tensor fasciae lata. At the end of closed reduction, you will find it very, very tight. Most of the things you have already reduced. So you may need to cut it sort of perpendicularly to get some sort of release in the tension. And then of course, wide capsular release is mandatory, and a low neck resection. So these are some of the tips and tricks that you need to incorporate. Probably you may need to go about it in a stepwise manner, but many cases you will find a very tight hip and then you will have to go the whole hog. So prosthesis selection, in the earlier days, we had not much of choice. We just had a monoblock. We had to get done with it. Most of the times we struggled with this. Nowadays, you have the modular hips. People have talked about customized prosthesis, but then restoring the offset, restoring the hip center is not always easy with a customized prosthesis. Probably it's not possible. So that's where the role of modular hips comes into play. So yeah, the customized hips, you have problems with restoring the offset, anteversion and the limb length. So like I said, the modular hips are definitely a boon. You can correct the anteversion, you can correct the offset and also restore the soft tissue tension or optimize the soft tissue tension. So that's the advantage of this. And overall, the hip biomechanics are improved and the longevity of the life of the THR is there. So this is one paper from, I think, China, which has talked about using modular hips in Coxavara, and they have looked at the follow-ups and they have done well with that. But even in modular hips, sometimes I will show you some examples from the literature. The trochanter is still high riding and it can abduct, the limitation of abduction may be there. What are all the problems? You can have sciatic nerve injuries like was already shown in the earlier presentation. You will need to do shortening osteotomy in many instances. You can have iatrogenic fractures as was shown in the earlier presentations in the morning. And my biggest problem has always been difficulty in reduction in spite of doing all the tips and tricks that I talked about. So here's one Coxavara that was not a conventional sort of Coxavara. It was due to an old proximal femoral osteotomy, which you needed to correct to get the limb length, the offset, and the restoration of the biomechanics of that particular hip. So this is in a post-iatrogenic sort of Coxavara. These are commonly the situations that we see, post-septic sequelae that have a very high riding hip, and then to get that down, your modular hips are very, very useful. And here the offset has been very well restored, and so this hip will do very well. This patient will have very good function. This, of course, I showed you earlier, a rheumatoid sort of situation. So again, the biomechanics have been restored, but the difficulties intraoperatively are always there. One needs to be careful. Osteoporosis, protrusio, and the tight soft tissues around, all those need to be addressed in a very meticulous and careful manner. So in a high riding hip like this, in this particular situation, in spite of using a modular hip, you see where the tip of the trochanter is in relation to the ilium. So here this patient will have limitation of abduction. He may have impingement, and in the long run, possibility of dislocation is always there, and also early loosening is a worry. So those are the things. In spite of modular hips, you can have challenges. And here's one with a Paget's disease, Coxavara, and done like that. These are not my cases, from the literature that is available. So in the light of all this, most of the times I struggled with these things, but here's one particular case that surprisingly was amenable to regular sort of a procedure. So that's why I'm showing this. Although I say that most of the times I struggled, probably the hip biomechanics were not restored very well. So here I would have expected a very difficult sort of scenario with this sort of a presentation, a tight or a very severe Coxavara with a high riding greater trochanter. And all these problems are there. You think about that, you plan about that, how to go about it, you have your armamentarium, and then you go about it. You get your CT. It is absolutely mandatory in such situations. As you can see that the posterior wall is deficient, so is the anterior aspect as well. So you plan to deepen this, the thing is go down to the teardrop. If you do that, then you will have probably get a small cup all the way in, without having to restore to a big cup, or you may at the most get to use a bone graft or a wedge. So just go through that. Yeah, just the steps of surgery. That's the shape of the head at the dislocation. You measure your offset, you do a very low neck resection, and then you plan to use the head for a bone graft. Wedges would be better. It incorporates better and lasts longer because some of these grafts can get resorbed. And of course, you need to delay weight bearing if you use a block graft like this. But you see, surprisingly, in this particular case, I could restore the offset. I could restore, in fact, probably I've lengthened the leg a bit, little bit. And so just to show that not all severe looking coxa can be difficult, what you need to be is you need to be prepared with all the armamentarium that you need. The important thing is to restore the biomechanics. Modular total hip is the way to go. And procedures like trochanteric osteotomy and other things, shortening, will add to the complications, so you need to be prepared. And at the end, perfect placement of your components is very vital to minimize the chances of dislocation. Thank you very much for your attention.
Thank you, Dr. Ajit. Any questions for Dr. Ajit? So, just one question, Dr. Ajit. So, we heard the previous Hemant speaking about DDH, which is very similar to coxa vara. But in coxa vara, there's one difference. Many times the head is even below the trochanter.
Yeah.
So, what difficulties, if you can just say, practically you face across an operating compared to a DDH patient?
Here, it depends on when the insult has happened to the hip. So in DDH, the acetabulum is very, very deficient right from the outset. Here, of course, if it's a post-septic sequelae, it can be there. If it's a post-septic sequelae, the same issue will be there because infancy, the acetabulum doesn't develop. But if anything, if the protrusio happens or the coxa vara happens at a later date for any other etiology, you will have a decent floor to put your cup in. You don't have to build up like you do in a DDH. But other than that, it is just getting your trochanter down or getting the hip center restored. That's the main issue. And occasionally, in the classic coxa vara, I have not had to do a shortening osteotomy, but things like DDH, yes, we had to do, or in that particular case where a varus osteotomy was performed, there corrective osteotomy needs to be done.
So one question to the panelists. In a pelvic discontinuity, do you have experience of using a distraction technique where you are not putting any cage but using a bigger cup, distracting the top and bottom fragments and letting it fall on the cup?
Right. So, very good question, Mrinal. I should thank you for this. So, for revision scenarios, it's a very good technique. So, distraction technique was first given to us by Paprosky and used many times for revisions. Particularly, so what you do is basically you distract the whole pelvis, put one size cup above it, and then you leave the distraction and you feel that the whole thing will collapse. That is very good if you have behind all soft tissues which are continuous. So you are basically distracting on the basis of the behind soft tissues. In pelvic fractures, you not only have the bones which are fractured, but the soft tissues also have been disrupted. So if you try distracting a pelvic fracture, it will just keep on distracting. So it doesn't seem to work very well as a routine for pelvic fractures or acetabular fractures. So there is a basic difference between revision scenario and an acetabular fracture.
Yeah, just to add, Dr. Hemant, the distraction technique actually works well in a huge acetabulum sizes. In India, we deal with smaller acetabulums. And whatever the implants, particularly this TM cups, whatever we have, the sizes are all for massive acetabulum sizes. So we have to be little careful what size we are dealing. And it works well with chronic situations. So in chronic situation, a distraction technique will work, but the right cup has to be selected. That is one. Second thing is, when we are using the distraction technique, we need not go back and do anything, do a bone grafting or anything. The distraction alone will take care, but we have to take care of the size, very important.
So as we all know, the lengthening the hip, the patient is not very satisfied. But in DDH and in Coxa, whereas when we bring down the hip center to the native to the opposite side, so how is the patient feeling? Because I don't have any personal much experience about that. So are they very comfortable comparing what was previous and now?
Yeah, most of the time that is the demand, that the leg length be restored. Like it was shown in the earlier case about girl coming at the marriageable age. Many of the times this is what happens. They are limping for their last quite a few decades, and that's when they come. If you have restored their limb length, the range of movement, they are not so particularly complaining, because compared to what they had, the range of movement, it is at least 50 to 70% better.
Okay, so the overall feeling is good because they have only one concern where it truly said that the limb length should be equalized.
Yeah.
But after equalizing, do they feel very normal like what they were experiencing for
See,
14
because
15
you give stability in type 4, if the patient walks with in an unstable hip, shortening and unstable. After the surgery, you are giving stability and also the length is, so definitely they are very comfortable.
I think the answer to that question is also basically restore the hip center, anatomic. Aim for the anatomic hip center restoration. In the bargain, you will have to do a subtrochanteric osteotomy if there's a supratrochanteric, and that's the question that Rakesh also already asked. So if there's significant shortening where the head is above the level of the teardrop and significant amount of supratrochanteric, obviously femoral shortening, but aim for the anatomic hip center. That will automatically bring back the limb length, and that will be the target that the patient also wants to achieve.
Yeah, okay, Dr. Mrinal?
Yeah, thank you, Doctor. I would like to thank Dr. Prasad for inviting me again to this Cawnpore Arthroplasty course. It's a pleasure being here. I'll be presenting on a common problem which we all face. A lot of trauma surgeons might be sitting here as well, where the PFN has been done for IT fracture and it has failed and the screw had cut out. So this is a case which I'll be presenting, which is a 66-year female. She was operated 2 years ago. She got a PFN done for a IT fracture. She comes to me with shortening, pain, limp, and her, infection markers are normal. I did the joint aspiration because with the implant in situ, it's always mandatory that you must rule out infection. So this is how she presents to me with a lot of shortening. And you can see the screw of the PFN has already been removed. So this was the initial X-rays, little poor quality. This was the IT fracture which was actually fixed with the PFN. I think they did a pretty good job as such, but due to some reasons it failed and the screw cut out. The surgeon just removed the screw. I don't know why he did not go in and intervene again, but she came in a neglected way to me after almost 2 years now. So this were the CT scans, and you can see there was a clear-cut non-union. The head is still there, but it's eaten up because of the screw being cut out, and obviously I had to intervene. So this is basically a video presentation I'll just describe. So this is a bird's eye view, and this is a close-up view of the surgery. I usually use a posterior approach for all my hips primarily, as well as in revisions. And you see I'm just cutting and exposing the implant there, and since there was a lot of shortening, I just preemptively released the gluteus max as well initially itself. So, a lot of surgeons, they mistake that they forget to remove the screws. I have seen surgeons shattering the femur while removing a PFN before a total hip arthroplasty. And you need to have that universal, the stem removal set available for the nail to be removed. And then you must locate your acetabulum. There will be a lot of fibrosis because of neglect and previous surgeries. And once you have a feel of the bone there, then you will be able to probably, extract the femoral head and reach to your acetabulum easily. So it can be challenging sometimes if the head is absorbed. There's a lot of fibrosis there. You need to clear it out. And once you see, I have, this is the towel. I put in the homens inferiorly. And then you do the medial reaming with the vertical reamer, initially with a small size to remove the medial osteophytes, if any, and do the standard reaming followed by gradually increased sizes of reaming being done inside of the towel and parallel to the towel. You do your trial insertion of the cup. So these are the standard procedures which you do in all the total hips. So, and then I've used, uncemented cup. And you can see that the posterior lateral border of the cup is little exposed. So that gives me adequate, inclination and version. So I'm pretty happy with that. I'm inside of the towel. The inferior border of the cup is inside. And once you've done that, you put your placement of the screws. I usually use 2 to 3 screws. And I've used an offset liner as well. So once this is the stem preparation, you start with the hand reamers gradually increasing in size. Now the reamers, the stem in this condition needs to be actually bypassing the distal screws of the PFN, because if you put a shorter stem, you will have stress rises and you can have periprosthetic fractures. So here I'm marking the tip of the GT, and this reamer needs to go actually to that part over there where the neck cut needs to be. And there is a marking on these reamers where you can see, which gives you the length of, according to the length of the stem you will be putting in. You can just, go inside and start reaming and go again and again until you get the desired fit which you require, in such cases, snug fit. So this is all done manually with your hand, and then you do a trial and you judge you see here, this is the posterior approach. I am putting it in a lot of version as is desirable, and I'm trying to go inside. And this is actually should be sitting at the tip of the GT. And once I had done the trial, I just found out that probably gradually I'm trying to hammer it inside, it's not going. I was expecting there would be leg lengthening. So I did more reaming, and I'm trying to put the stem further distally inside so that I can just, do some shortening or maybe, approximate the length on both sides. This is also done manually. And then you can see I'm again doing a trial here in the desired anteversion, and I've done the reduction. So this is the trial reduction which is being done. And then you again go inside, do preparation of the stem. This is done, final preparation is done with the reamers on the drill. So once you've seated this part at the tip of the GT, that means your stem is going to sit in its proper position in the proper length which is required. So I'm marking on the trial, I'm marking the version where I'll be placing my final stem. This is a monoblock stem which I'm using here. It has a lot of distal flutes to get press fit fixation. And you can see that it's gradually being hammered inside, and I'm seating well. And then I do the reduction. And you can see in the top view, I am doing a trialing in all the positions, full extension, no tightness. And you get good intraoperative stability. So this way you bypass the screw holes so that there are no stress rises, and you get a good leg length alignment version and do absolute watertight closure. Thank you. So this was the final X-ray of the patient. This was the intraoperative picture. This was the stem used. This was me checking on table that I've got a snug fit. And these are the final X-rays of the patient. So see the screw is here of the PFN, and I've gone past almost 2 to 3 cortical diameters, and I've got a good fixation. I thank you. And before I end, I want to tell you that my new book on hip arthroplasty this is the cover, which is just recently being sent by Springer to me. It's going to be published soon and will be available in the market and Amazon as well. Thank you.
Thank you, Mrinal. Any questions for him? Simon, you want to load? So any questions for Mrinal?
Sir, a very well done case. Just one question. There have been recent papers regarding the use of primary stems in these trochanteric fractures. So what's your take on that?
I'll cover it in the topic.
Yeah, I have actually myself used many stems as like I've used short stems as well.
Mike.
I've used cemented stems as well in, failed DHS, failed PFNs. I've used short stems as well. But the recommendation is to avoid future complication, further complications, especially the ones with the PFNs who have two distal locking screws if you've used them. It is better to avoid the stress rising and bypass those screws. And with the neck being not there in this case, it is better that you can control your version better with these kind of stems.
If you use a two-stage technique, remove the implant first and then wait for a month and then go in with a simple stem.
No, if you've aspirated, there's no infection, it's quiescent hip, why would you wait for 2 months?
Okay.
You can go in directly. If you are wary of any kind of infection, then you can think intraoperatively for a 2-stage and do send some cultures from the tissue and the bone once you're operating.
Yeah, do you send histopathology, because these are, one worry is the infection because these implants have been lying for so many years. So do you look for your neutrophils intraoperatively or something?
Yeah, you saw that tissue I was removing, that has gone for biopsy as well as tissue cultures and the head also.
So frozen section?
Yes, I have seen, I did a hip in one case one time and this was also neglected and that came out to be a tumor later on, a lung metastasis. The patient had no symptoms at all. On table also it didn't look like a tumor and on the x-rays also, but it came out to be a lung metastatic.
One question from panelist. When we are using a modular stems, I've seen 90% of the surgeons are preparing the stem outside, putting proximal and distal part. How many of you are actually first putting the distal part first and then checking the modularity with the top part?
No, the concept of modular stem is that.
So is there any tip in that, once you put your distal part inside and then check the bodies and how difficult, because people are scared of using it the way it is designed to be used,
No, but ideally you have to get your distal fixation. So that rigid fixation has to be there. The moment you do that, the next part is getting your offset correct. So that all the proximal part what you are going to attach, so your offset and the length correction.
So you put your final distal part in?
No, not the final distal part. You put your trial distal.
That you all do?
Get that, I'll just say quickly tell the sequence. Put the distal trial, get your size correct, then you trial the proximal portion, get your assessment and then what sort of size you will be going and how your offset and length. Then what you do, select the distal, select the original, put your distal and then you don't put your trial. You can, if you're a little doubt, you can put your trial. Otherwise, you can go ahead and do the original. But you have to do it in 2 different sequences. That is one. The most important thing is the junction of the modular one has to be covered with bone. You should not leave it open. So that is the most important thing. Whatever the bone is available, you bring it across, put the graft and then wire it. So whatever failure happens in the modular stem is at the junction, the breakage of the junction.
So, Hemant, so just coming to your point, so we have 2 different philosophies. One is complete modularity where you start off, get your distal part right, even fix it actually and then do. The other is complete monoblocks right from start. So the current literature, you'll see all the new companies who are coming in, even including our own Indian implants, that you actually ream separately for distal, ream separately for proximal, but get a monoblock stem. So that's the way we are moving forward now.